Good morning and welcome to session 2 of our 2024 Arizona Cancer Registry Annual Educational Workshop. I'm Juliet Wilkins and I'm the Training and Policy Manager for the Arizona Cancer Registry. We're so glad you're with us this morning. As you should see on my screen, we've got a full agenda for today. We are going to be covering site-specific abstracting for lung and esophagus. And then we will end with a formal Q&A session. We have a special guest presenter today, Dr. Peter Baik from City of Hope. So to be respectful of his time, we will take questions for Dr. Baik right after his portion of the presentation. And then we'll take all the other questions when we do the Q&A at the end of today's workshop. So just a reminder, use the chat to communicate with each other or with us. If you have any questions about the presentations, please put those in the Q&A chat so that we can find them more easily. And we will do our best to answer all of the questions that we can in our Q&A session. But any questions that we don't get to, then we will be sending out a Q&A document at the end of session 4. So you'll be able to see all of the questions and the answers at that point. You are eligible to earn 2 CE hours for today's workshop if you attend all 4 sessions. We have been approved for 8 CE hours total, 3 of which are going to be category A CE hours. And you should have received a CE tracker in the mail or in your email so that you can keep track of which sessions you attended. And then at the end of session 4, I'll be sending around the CE certificate so that you can get credit for any and all of the sessions that you attended. So let's go ahead and get started. Our first presenter this morning on lung and esophagus is Dana Doyle, our cancer registry epidemiologist. She joined the ACR back in 2022, and she holds an MPH in epidemiology and biostatistics from Penn State College of Medicine. And during the past year, Dana's given a number of presentations, both at the state and the national level, including speaking to the Arizona Cancer Coalition, the Cancer Health Equity Summit, the Arizona Melanoma Task Force, and the NPCR Community of Practice. And we are very grateful to have Dana working with us. She just does such a fabulous job with our cancer registry statistics, and I'm excited to hear what she has to tell us about lung and esophagus cancer in the state of Arizona. So give us just a moment to move seats around in here, and we'll be right back with Dana's presentation.
Hello, everyone, and thank you, Juliet, for that introduction. Like she said, I'm Dana Doyle. I'm the Arizona Cancer Registry epidemiologist, and today I'll be going over lung and esophageal cancer. I'll also be doing basically a refresher of my presentation last session, just going over some state cancer statistics just to ground us in today's topics as well. So this will be brief and hopefully a refresher and just get us started for the day. Okay, there we go. So it's important when we talk about Arizona Cancer Registry statistics and trends that we remember the impact of the COVID-19 pandemic. So we did see this impact in our cancer registry reporting numbers, specifically for 2020. And we also saw it for 2021. The numbers for 2021, we did see an increase, but not back to pre-pandemic numbers. So when we look at these trends, just remember that when we see a decrease, we have to remember, is this due to because people are being diagnosed with cancer at lower rates, or is it because we are seeing delays in diagnosis, lack of screening, disruption of patient treatment, follow-up care? and contracting health complications due to COVID-19. And so I'm going to be using some terms throughout this presentation, such as incidence, which is the number of new cancer cases. Mortality refers to cancer deaths. And I'll be saying the word rate a lot, which know that I'm talking about age-adjusted rates, which is the number of people who are diagnosed or died from cancer for every 100,000 people in Arizona. And this presentation contains the latest data that we have available. So for incidence, that's going to be data for diagnosis years 2017 to 2021, and for mortality 2018 to 2022. Here you go. Okay, so we're going to start with incidence today, which is our new cancer diagnoses. And so for the past 5 years of 2017 to 2021, we saw approximately 396 invasive cancer cases diagnosed for every 100,000 people in Arizona. And looking between 2017 and 2021, we did see a decrease of 6.4%, with a notable drop in cases between 2019 to 2020, which is that pandemic years. And overall, represented in that red bar, we do see that males have higher rates of invasive cancer compared to females. And the cancer sites responsible for the most cancer diagnoses in Arizona is female breast, lung and bronchus, prostate, colorectal cancer, and melanoma. And looking at mortality, so between 2018 and 2022, we saw that for every 100,000 people in Arizona, we experienced 134 cancer-related deaths. The rate for cancer deaths has decreased 3.6% between 2018 and 2022, with less fluctuations than we see in our diagnoses with incidence. And once again, the same with incidence and diagnoses, we do see that males have higher rates of cancer deaths compared to females. And the cancer sites responsible for the most cancer deaths in Arizona are lung and bronchus, colorectal cancer, pancreatic, female breast, and prostate cancer. Right, so now we'll be going into our site-specific cancer statistics, which it will be the beginning of today's topics of presentations. So looking at stage of diagnosis and diagnosis here, the way we group stage of diagnosis for this presentation and for our publications is in 3 groups. So early stage is our in situ and localized cancers, late stages regional and distant, and unknown stages that we did not receive any documentation regarding stage of diagnosis. So on the left of the slide, we have lung and bronchus cancer, and we can see that we've maintained pretty steady numbers throughout 2017 to 2021, with an average of 60% of lung and bronchus cases being diagnosed in late stage. So it is being more advanced at the time of diagnosis. And on the right side, we see similarly for esophageal cancer, between 2017 and 2021, we saw an average of 58% of cases being diagnosed late stage. And this will be a refresher from my last presentation. So just going into lung and bronchus cancer. Lung and bronchus cancer is the second most common cancer diagnosis in Arizona. And within 2017 to 2021, we saw an average of 4,049 Arizonans diagnosed with invasive lung and bronchus cancer at a rate of 42.7 cases per 100,000 Arizonans. Like I said on the last slide, approximately 60% of lung and bronchus cancer cases are diagnosed in late stage. And looking at the breakdown of our Arizona populations, see that Mojave and La Paz County have our highest rates of lung cancer diagnoses. And looking from 2017 to 2021, there was a decrease in 7.4% between 2017 and 2021. And for race ethnicity, we do see that white non-Hispanic individuals are diagnosed with lung and bronchus cancer at high rates, closely followed by Black and African Americans in Arizona. White non-Hispanics with 48 cases per 100,000, and Black and African Americans at 44 cases per 100,000. And overall, males do have higher rates of lung and bronchus cancer diagnoses compared to females. And for mortality, we saw that for lung and bronchus cancer, it is the leading cause of cancer death in Arizona. Between 2018 and 2022, an average of 2,563 Arizonans died from lung and bronchus cancer each year at a rate of 26.3 deaths per 100,000 Arizonans. And the same with incidence, we saw that Mojave and La Paz County have the highest mortality rates for lung and bronchus cancer. And by by year of death, we saw a 17% decrease from 2018 to 2022. For instance, we saw that white non-Hispanics individuals in Arizona were diagnosed at higher rates for lung and bronchus cancer. And for mortality, we see that white non-Hispanic and Black and African Americans in Arizona are dying at equal rates of lung and bronchus cancer at 29 deaths per 100,000 Arizonans. Right. So our new slide for this presentation, everything was a refresher. So now we have esophageal cancer, which is the 19th most common cancer diagnosis in Arizona. And we saw on average between 2017 to 2021, 388 Arizonans were diagnosed with invasive esophageal cancer each year at a rate of 4.2 cases per 100,000 Arizonans. And like we said, approximately 58% of 58% of esophageal cancer cases were diagnosed at late stages within those 5 years. And looking by diagnosis here and by sex, we did see a decrease of approximately 11% between 2017 and 2021. And very notably, males in Arizona have much higher diagnosis rates for esophageal cancer compared to females, approximately 5 times higher for males compared to females. And looking at by county, we see Cochise County, Mojave County, and Yavapai County have our highest esophageal diagnosis rates in Arizona. For race ethnicity, white non-Hispanics in Arizona have the highest rates of esophageal cancer diagnoses, followed by American Indian and Alaskan Natives. And this will be our last slide from my presentation. So looking at mortality, we do see that esophageal is the 11th most common cause of cancer death in Arizona, with approximately 336 Arizonans dying from esophageal cancer each year at a rate of 3.5 deaths per 100,000 Arizonans. And once again, we saw with incidence, and we see the same trend with mortality, that males are dying of esophageal cancer at higher rates compared to females, approximately 6 times higher compared to females. And for a county, we see the same counties having the highest mortality rates, but just in a different order, with Yavapai County, Mojave, and Cochise County having the highest mortality rates. And for race ethnicity, we saw white non-Hispanics being diagnosed at higher rates, and we see them also dying at higher rates of esophageal cancer compared to all other race ethnicities at approximately 4 deaths per 100,000 people. Okay, so that is my data heavy presentation. So thank you so much, and I will hand it off to Juliet.
And Georgia, I believe you wanted to do Dr. Baik's presentation.
Oh, I'm going to say a few words, and then Juliet will follow me with the formal introduction of Dr. Baik. But I did want to say a few words just to first thank Dr. Baik for presenting today. I worked with Dr. Baik in the policy work group related to the Arizona Cancer Coalition, and he's been very supportive of our cancer reporting objective. I know we communicated a lot through email trying to develop the objective and strategies, and so I wanted to kind of thank you for that process and so for being so involved with the coalition. I know I'm looking forward to our work together in improving cancer reporting in general for the state. So I'm going to turn it over to Juliet to kind of do the formal introduction and provide your background. So Juliet.
Thank you, Georgia. Dr. Peter Baik is the current Cancer Committee Chair for City of Hope in Phoenix, Arizona, and he serves as the Cancer Liaison Physician, and he's also a member of the Medical Staff Excellence Committee. Dr. Baik is a thoracic surgeon and the former chair of the Thoracic and Cardiovascular Discipline for the American College of Osteopathic Surgeons. He spent 5 years as the adjunct clinical assistant professor of surgery for the Oklahoma State University Center for Health Sciences College of Osteopathic Medicine. And please welcome Dr. Peter Baik, who is going to be telling us about staging and treatment for lung and esophageal cancers. Thank you, Dr. Baik.
Thank you, Juliet, and thank you, Georgia. I mean, I moved here about a year ago. Can you guys hear me okay?
Yes, we can.
Okay, perfect. Yeah, my Zoom audio thing was giving me trouble yesterday. So, but yeah, so I moved here to Arizona permanently about a year ago, and there's a lot of need for diagnosing and treating lung cancers for Arizonans. And so actually, it's really nice to be working with you guys, especially with the Arizona Cancer Coalition, and to make sure that patients are getting the appropriate diagnosis and treatment in a timely manner. And so I'm gonna share my screen if it's okay with you. Let's see, share screen. Where's my other screen? Nope, not that one. Okay. So let me do this. And again, thank you for allowing me to kind of talk to you guys about lung cancer or lung and esophageal cancers and kind of staging. And so when I was preparing this presentation, I was thinking, okay, how am I supposed to present this? But then I was able to obtain the Cancer Registrar Guide, and I found some interesting things. So I kind of based the presentation on that, and some of the things that are interesting, like the bullet points. And so today's objectives are to one, overview of lung cancer, two, overview of esophageal cancer, and then three is discussion. I think discussion is really important. And I know they said don't ask questions right away, but if you do want to if you do have any questions, just ask verbally, because I can't really see the chat box when I'm sharing. Or actually, let me do this. This one, I'm gonna move this one this way. And yeah, just ask me. You could even put it in the chat box now. I should be able to see it now. So I think it's important, especially that we don't forget to ask the questions, and it's much easier to answer the questions at the time. So this is from the cancer.org, and with the Arizona new case estimates with the lung cancer 4,350 in 2024, and death for lung cancer is 2,380. I mean, that's a lot of Arizonans dying from lung cancer, and so we would definitely want to improve that. And so the lung cancer rate, if you look at the rate of new lung cancer, we're actually up here. So the new cancers in Arizona is actually better than most of the states in the U.S. or above average tier, and this is through the City of Lung Cancer, the American Lung Association's website, which is an excellent resource. And or over the past 5 years, the rate of new cancer cases improved by 20%. The survival rate is still the average here, and it's getting better, but it's not significantly better. I mean, it says it's improved by 20%, but it's still, we're still in the kind of the middle of the pack. So, but this is the one that we really have to focus on, is because of the only 27% of the cases are found in early stages, localized, being confined to primary sites. And so we know that the overall 5-year overall survival, and we know the morbidity associated with treatments is much lower when the morbidity, but the overall survival will be much higher when the patients are found at earlier stage. But then, of course, there are a lot of patients who are found to have metastatic disease and local regional disease as well. So when you guys are putting the data into the registry, it's really important to put in the accurate data. And so that's why, we're hopefully we could answer some questions to make it easier for you guys. So the surgical treatment, which is really sad for me, and that's one of the reasons why I kind of moved here, because I saw a lot of more needs here than in Chicago area. And so you could see that our surgical treatment rate is actually 41st out of 47 states with available data, which is really, really sad. We should be at least here. Of course, you want it to be in here. But it's not like we don't have enough thoracic surgeons, but I think because we do have kind of delay in getting the patients, especially from the outlying areas of Phoenix or Tucson. And so, it's something that we're definitely working to improve it. And part of it is to increase the lung cancer screening. And Georgia mentioned, working with the policy group and with the Arizona Cancer Coalition. That's what we're trying to improve as well. The lack of treatment, or 46 out of 47, which is really, really embarrassing. And I'm actually going to talk to, I think there's a Cancer Action Network. So I'm going to mention this, how bad our treatment rate is, which is really embarrassing. I think one of the best ways to get the politicians to act on anything is to embarrass them. And then one other thing is the high-risk screening rate. Our screening rate is only 1.3%. I mean, that's really, 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 really sad. And so this is something else that we're working on. And so types of lung cancers. I mean, this is not even everything. I mean, there are more stuff that's out there. But do you have to worry about all these things? Individually, no. Whenever I put the cancer data into our, we use Epic and our staging. When we place subtypes, for example, for adenocarcinoma, I try to put the acinar papillary, but a lot of times these are mixed. So, but these are all the potential lung cancers that can occur or form types, and so we see a lot of these things, and it's quite exhaustive. So, common types of lung cancer. And this is not just about staging, but just to kind of have a basic science and kind of understanding of what lung cancer is, what the anatomy is, and how we, what's kind of the basis. And to me, if you're inputting data, you have to have an idea of what's going on. And so I just wanted to kind of clarify a lot of things if it's not clear to you guys. And so here's lung cancer. So we separate them into kind of 3 different generalized categories. Non-small cell lung cancer, which is the most common, small cell lung cancer, and then other cancers, sarcoma, which is not common, it's a bad actor. Carcinoid tumors, on the other hand, could be a really good actor, meaning patients can live a really long time, even with quote-unquote stage 4 disease, because it depends on the biology of the tumor and how they behave. And so within the non-small cell, then, we divide it into adenocarcinoma, squamous cell carcinoma, large cell. Then you got the anosquamous carcinomas. And this is like really important to know because we may stage it as adenocarcinoma, but when I do the surgery, sometimes we find that there's a squamous component to it. And you could have both within the tumor, so that can confuse the matter. And then there's a pulmonary enteric adenocarcinomas, and a lot of times you may have mucinous adenocarcinomas, meaning the cancers are forming or producing mucin and excess mucin. And so a lot of times that's seen in the gastrointestinal colon cancers. And so people get confused, hey, is this colon cancer that's metastatic? So we end up doing a metastatic workup, but a lot of times it's in the lung itself, and it's a primary lung cancer. So systemic therapy. I want you guys to remember all this so that you guys can put. No, I'm kidding. No. Important thing is that there are so many different types of systemic therapies. This on the left side is the kind of the chemotherapy, the tried and true chemotherapies, and we say platinum doublet. And cisplatin and carboplatin, that's the most commonly used. But we do have now all these mutations and targeted therapies, and so many drugs are coming out. It's amazing. And like the cancer cells have developed mutations to, for example, EGFR. And so then now they're developing more drugs to target the mutations of the mutation or the genetic abnormality. And now they have another line that combats another mutation. And so it's cat and mouse kind of phenomenon of treatments. And it's amazing how these things are coming up. But the important thing is, what's the difference between chemotherapy and targeted therapy and immunotherapy? So chemotherapy, again, one of the things is about chemotherapy is what is chemotherapy? Well, chemotherapy, the carboplatin, cisplatin, things like that, what does is it actually attacks the cells, malignant cells themselves, and it causes DNA repair mechanism to be broken so that it doesn't survive and it dies and causes apoptosis, meaning the cell to break open. And so a lot of times, chemotherapies are, whenever I tell patients is it's more like a poison because you can't just say that, cisplatin will just go into the cancer cells. It does affect other normal cells. And so when you give the systemic therapy, patients can have a lot of side effects. So I tell patients it's a poison that we're trying to kill the cancer cells without killing you. And so that's why there's only so much chemotherapy that we can give. And there's only, the complications that we have to, or the side effects that we have to deal with. What is targeted therapy? Well, cancer cells, even though they're microscopic and tiny, and they never went to any, college, med school, grad school, don't have PhDs, but they're kind of really smart. And so how do they evade the immune system? And they have, within the cancer cells, they have targeted, not the immune system, but for the targets of the, like the signaling pathways. They have that regulates cell death, division, program, and growth. And so what it does is there are pathways that these drugs, so EGFR, for example, you could see mutation. It attacks phosphorylation of this receptor. And so when this receptor is working, it allows the cell to proliferate. So instead of just attacking the DNA, but you're targeting individual mutations within a lot of times the cell receptor. So that's why we call it targeted, because we're targeting the specific enzyme or pathways, not just disrupting the DNA. What is immunotherapy? Well, immunotherapy, so the cancer cells are basically cells that were supposed to die, but decided that, hey, they do not want to die. They want to live forever. And so then how do they do that? Well, our body, our immune system knows to attack those cells that have aged. I'm sure you heard about telomeres and aging of the cells. Well, at a certain point, our body knows to attack those cells if it hasn't died by itself, that to get rid of it. Well, these cells have developed mechanisms to evade those signaling mechanisms, and so that it evades the immune system. So one of the big thing right now is the PD-L1, PD-1 receptors. And so what it does is with the immune escape system, when there's a T cell wants to see if the tumor cell is foreign or something that needs to be attacked versus our own immune or from our own body ourselves. And the tumor cells have these receptors that actually kind of hide themselves and telling the T cells that, hey, I'm still I'm still good, so let me live. And then what happens? They proliferate. But then when you give anti-PD-1 drugs, you're not killing the tumor cells per se directly. What you're doing is you're allowing the immune system to recognize that the tumor cells is not self, and so then we can, or the immune system will destroy those cells, rogue cells. Then these are all the types of immunotherapies, but right now, the ones that are most commonly used are the immune effector cell modulators. And I'm sure you guys heard about CAR T as well. But important thing is these are the ones that are being used. So sometimes it gets kind of confusing between targeted therapy and immunotherapy. But important thing is that all these biomarker testings and all these genomic mutations of the tumors are being done, or neogenomic studies, or and so then we can tell, hey, if there are mutations, we could target it. And so that's kind of the basic difference. And I'm not going to go into the actual mechanisms because I have no idea, because it's very confusing. So one of the questions is, before I go to the anatomy portion, one question, there's a lack of treatment provided outside in private MD offices. And so that's one of the things that I'm trying to do when it comes to the private physicians is I go out and meet with the private physicians. I do present at regional meetings. For example, the American College of Osteopathic, or Arizona Osteopathic Medical Society, for example, which has a lot of primary care docs. I go out there and tell them, or if there are other meetings, I present to them. And we're trying to develop a lecture series so that we could target to inform primary care providers so that they know that the patients have options. It's not just the primary care, but private docs, oncologists, even some of the oncologists, especially in smaller areas, are a lot of times they're so busy, and so they just they don't, and trying to get the referrals, it's not easy getting someone to go see a thoracic surgeon or interventional radiologist. So they treat those patients because they don't want to not treat them, but and so that's why we have to educate the providers to make sure that they know what the most updated treatments are. So anatomy wise, so this is a CT scan. This is sagittal, meaning looking from the side. This is front to back view. And I chose this is because it really shows the lung segments really well. So right lung has 3 lobes: upper lobe, middle lobe, and lower lobe. And then left side has 2, upper lobe and the lower lobe. And a lot of times you could have fissures. And for you guys, when you're sometimes questioning, hey, what's the T stage? Is there a visceral pleural invasion? A lot of times, sometimes the tumors can invade here. And sometimes, patients, the surgeons may say, hey, I did an upper lobectomy, unblocked resection of lower lobe. But then they don't mention anything about tumor going through the the visceral pleura, but because in an ideal world, everyone will have this lining. And so if a tumor grows through and goes into the other lung, then you should be able to see visceral pleural invasion. Well, this is ideal, but it doesn't happen that way. Sometimes we see patients without fissures, so this could be just more or less equivalent to the left upper lobe. So left upper lobe is equivalent to the right upper lobe and the middle lobe. Imagine just now without this line. And so sometimes I have patients that develop lung cancer here, so I may have to cut here, but it's coming mainly from the upper lobe. Then I do a wedge of the lower lobe. But staging wise, is that when you input visceral pleural invasion, is there really a visceral pleural invasion? No. Is this two different lobes? Yes and no, because it's gonna grow and there's no barrier to, and we're not saying that this is going to, it's not even a direct invasion per se. I guess you could say that it is, but it gets really confusing. And so, the most important thing is if you guys have any questions when it comes to staging, T-staging, or clarifications, it's really important to kind of ask the surgeons or their care managers. So the thing that we talk about now is we say anatomic resection. What is an anatomic resection? Well, anatomic resection is when we isolate the pulmonary artery, pulmonary vein, and the bronchus going into that particular lobe. But anatomic resection can also be segmentectomies. Upper lobe has 3 segments, lower lobe has 2, and middle lobe, and then the lower lobe has actually 5, but equivalent to about 5. And so these are the segments. Each segment has its individual arteries and veins. And so instead of having to take the entire, say, upper lobe, we're able to target just cutting the upper portion of the upper lobe, or apical segmentectomy here, or superior segmentectomy here. And this is a lot of times the most common segmentectomies that are done. Superior segment, because that's really easy, or lingular segmentectomy. If you have a lingula, that's kind of like almost like a middle lobe equivalent, but they call it segmentectomy. So that's what segmentectomy is. But important thing is that those are all anatomic resections. What is a wedge resection? Wedge resection is you just get a stapler and just go across, or just cut, not respecting the boundaries, or not respecting per se, but not following the arterial and venous and bronchial anatomy trees to make sure that you get all the tissue from within that segment. And so wedge resection is, just imagine just going across. There's also a question that is wedge resection kind of equivalent to almost like a segmentectomy if you do a big enough wedge resection? Yes and no, but a lot of times you don't actually get the lymph nodes around the supplying artery and the vein. So this is another thing. I remember going through the packet was that the phrenic nerve involvement, left recurrent laryngeal nerve involvement. Well, all those nerves are, for example, here's the left side, are located here. So if the tumor develops, or if the lymph node develops and enlarges, it can actually push on the phrenic nerve, or it can actually push on the left recurrent laryngeal nerve. And when it does that, you're going to have vocal cord paralysis. And so then you become hoarse. And so I tell patients, hey, you're going to sound like the Godfather from the movie. And so you're going to be very deep voice, can't talk, and not be able to talk and not be able to sing. And so that's why this area, for example, looks big, but if you actually go in, that area is 2-3 centimeters wide. In that area, it has all these critical structures. On the right side, it's a little easier because The left recurrent laryngeal nerve is not here. The right recurrent actually goes up here and goes up. Well, of course, if you have a metastatic disease here, or pancreas tumor, you could have brachial plexus lesions. All these things can cause mass effect. So lymph nodes. So, you say, okay, lymph nodes wise, what is a lymph node? Well, lymph nodes are everywhere in our body, but it has major channels. In the lung, what it does is, from the lung itself, the lymph node drainage usually goes towards the center and then follows cephalad towards the head, and then drains into the left subclavian IgA junction through the thoracic duct. So then when you were staging, we talk about N1, N2, and N3. But then how do you know what's N1, what's N2? The easiest way that I tell people is, if it's single digit station, it's either N2 or N3 node. Why? Because single digit stations are in the middle of the chest. It's all in the mediastinum. It's a paratracheal 2R, high upper paratracheal, lower paratracheal 4R. But when it becomes double digit, then that means it's a bronchial node, still regional, but now it's hasn't gone into the mediastinum yet. Of course, 10R node sometimes can be enlarged and goes into the 4R space, and we have to use anatomic boundaries. But is that always true? And so, and do we want to make it a higher stage than what actually is? No, but treatment-wise, if there's a question, is it better to go with N1 disease or N2 disease as staging so that they could get adjuvant therapy? Well, if it's N1, you could still get that, and so sometimes it gets kind of very confusing which one would be the best for the patient. But with the advent of the immunotherapy, and right now for N1 and N2 disease after surgical resection, we don't give immunotherapy, but that's going to come soon as an adjuvant therapy. Right now is chemotherapy. And so now whenever I see patients, even patients who have N1 disease, stage 2 patients, or even stage 1B, it depends on what the tumor's looking and how it's behaving. I may just do neoadjuvant chemoimmunotherapy. And right now, chemoimmunotherapy, up to 25% of patients can have complete pathologic response. And I guess I should talk a little faster, maybe. So here's atelectasis. What is atelectasis? This is what it looks like when it's atelectatic. This is a lung that's been deflated during surgery. I cut this one, but you could see how it looks just kind of big deflated balloon. And so what it looks like on CT scan is that you see the lung parenchyma, all the alveoli has just shrunken down, but you still see the airways, because airways has cartilaginous ring, so it shouldn't really collapse per se. So that's why you're seeing all these things. Like this patient has a hernia that's pushing the lung. So now this lung has become really atelectatic. So this one, I had to draw it because I didn't want to mess with the copyright and all these, things. But what is the difference between bronchopneumonia and obstructive pneumonitis? Well, bronchopneumonia is when you have pneumonia infection of the airways and extending into the alveoli. Okay, and obstructive pneumonitis is when there's a tumor that's obstructing the airway, so that whenever there's an airway produces fluids and mucus and things like that, so that it can actually get rid of all the foreign materials. And so that's why smokers, when they quit, the hairs or the cilia within the airway wakes up at about 2 weeks mark, and then it gets rid of all the junk that's in there. Well, imagine if there's a tumor there, what's going to happen? All that stuff can get out, fluid fills, and what does bacteria love? Warm, moist environment, and with tons of food. And so then what happens is you get this kind of pneumonitis and eventually atelectasis. And this is my representation of atelectasis. I know it's kind of funny looking. My kids were laughing at it. So here's a case. This patient had this lesion here and got a CT, and you could see that there's something going on here as well. So when they biopsied it, they biopsied this lesion. And so what it showed was multiple fragments of benign alveolated lung tissue with fibrosis, scarring, inflammation. But should I be happy with that? No, I shouldn't be happy with it. But this was done outside, and they were like, oh, okay, you don't have lung cancer. So the patient, went on his own. And then several months later, he's like, hey, I'm still not feeling, not getting better. And so what happens? They do another CT scan, it's worse. And actually it was cancer, but this was obstructive pneumonitis. So it's really important that whenever we see something and it doesn't coincide, or, this looks like there's a mass there. Why is it just doing, having an infection or chronic fibrosis? Then you have to question and get a second opinion. GGO with solid component. What is a GGO? GGO, ground glass opacity. So whenever I take patients, you get this clear glass, painted glass, and you're sandblasting it. And so then you get these kind of hazy ground glass. But the ground glass could be from inflammation. It could be infection. But the thing that we always worry about is formerly known as bronchoalveolar carcinoma, BAC, but we don't say that anymore because we have to make it more fancy. Now we call it adenocarcinoma in situ with lipidic pattern. So what that means is cancer cells are spreading along the airway, but it's not actually invading. And so then what happens is that when the airway, so imagine here's this. If the cancer cells are, don't think of it as bronchopneumonia. Now think of it as a lipidic pattern, or the adenocarcinoma in situ. These tumor cells or precancerous tumor cells, and sometimes are not really going through the airway, but it's just growing along the airways. So then these airways are very small. A lot of times it's microscopic. So what happens? You're going to see that you're not going to see it as a solid lesion, but as kind of fuzzy area. But once it becomes invasive, then it's going to start looking more solid instead of just growing here, but solid lesion. So then you start seeing the solid components. So whenever we see solid components, there's about 30-40% chance that there could be invasive cancer in it. So what is a separate tumor in the same lobe, T3 versus different cancers or synchronous primary cancers? Well, this patient had this lesion here in the upper lobe and had a separate lesion here. And so they biopsy this, and could this be same? Could it be different? Yes, it could be different, but it's in the same lobe. And the lesion wasn't there in a previous CT. So all CTs are really important for us to compare and contrast what's going on. And so whenever we see OCT and, hey, you got this lesion wasn't there and this solid round thing pops up, then we know that that's most likely metastatic. Of course, you could always biopsy, and biopsying is really important if you can, but that, we shouldn't waste time biopsying it if it looks like a duck and quacks like a duck. Why is ground glass really important? Well, here's this patient. It's a multifocal disease case. Here's area of ground glass opacity with solid component, but he also has this solid component areas. So whenever there's metastatic disease or going to different lobes, just think of it as it's not going to grow within the airway itself. It should not have ground glass opacity. it should be more solid because now it's spread. I mean, yes, there's an entity called spread through airway spaces, but usually we say that when it's in the alveoli, not within the airway itself. But it spreads by the lymphatics and blood. And so by definition, what's going to happen? That cancer is spreading and it's already outside the bronchus. So when it grows, it's already invasive. It should be solid. That was weird. Can you guys still hear me? Because my headphone just went off.
Yeah, we can still hear you.
Okay, good. And so maybe it's saying I'm talking too fast. But here's the way when we biopsied it, there is one tumor here. And then when they biopsied this was tumor as well. And whenever you see ground glass opacity with solid component, the chance of being metastatic is very small, not zero. Especially if this becomes metastatic and it looks like this. How come this is not growing, yet metastatic disease is growing this fast? But we know that this shouldn't cause ground glass opacity to show up like this. And then he had multiple ground glass opacities and some solid components as well. So after neoadjuvant therapy, I actually took him to surgery to get rid of this lesion and to get diagnostic confirmation that, hey, these are multifocal disease. And it was. And so that's the difference is sometimes it's not easy to tell if it's multifocal disease. And we get, even though I said, it looks like a duck, quacks like a duck, sometimes we could be tricked. But we have to ensure that the patients get, if you see multiple tumors, it's already wanting to spread to other areas, not just in the lung, but in the body. So we got to start the systemic therapy. Of course, if the biopsy can be done within a week, yeah, okay, go for it. But if it's going to take 2, 3, 4 weeks, or even a month, 2 months, 3 months, you shouldn't waste time. You got to start something. So here's another cancer patient that I actually recently operated on. Patient had this lesion and tiny little lesion, and another one here. And so they biopsied this and they said it's invasive solid adenocarcinoma with mucinous differentiation. And they didn't biopsy this, and they were calling it a T4. Okay. Well, could this be T3 in a separate lesion? It could be. So because the size of the tumor where it's located, they said it was not really easy to biopsy. And so I took this patient to surgery. So these two, red and yellow, were same type of tumor. So it was a T3 lesion, but also this was a papillary adenocarcinoma. So it definitely can confuse people. Visceral pleural invasion. What is visceral pleural invasion? These are again, copyright issues. Here's the surface of the parietal pleura. Here's the visceral pleura. Visceral pleura is the lining on the lung. I use this CT because there's fluid separating it. And here's the parietal pleura. And so and then important thing is the elastic layer. If it invades the elastic layer, there's a visceral pleural invasion. But then there's PL1, PL2, PL3. PL3 is now outside the lung and going to the other. But that's why elastic staining or elastin staining is really important to differentiate between PL0 and PL1. Once it goes through, they have to look at the pleura itself, if it's going outside of the pleura or abutting the pleura or the lining of it. So here's a patient, did a neoadjuvant chemoimmunotherapy, obviously going through the pleura into the chest wall. After neoadjuvant chemoimmunotherapy, she responded well. I took it out. This thing did not have any cancers. It was amazing. But here's the pleura, and this is what it looks like. It was thickened, but there was no cancer cells. What is EBUS? You're using a small ultrasound to look at the lymph nodes. And biopsying the lymph nodes. And so this is what it looks like using a needle and going biopsying the lymph node. And so then what happens is using a bronchoscope, you look and biopsy. Because of this procedure, the sensitivity is so good that now I don't do mediastinoscopies anymore as much. I just realized that I have until 12, not 11 to talk. Why am I talking to them so fast? I looked at the clock wrong. So what is mediastinoscopy? Mediastinoscopy is when I make an incision just above the sternal notch, and I insert the scope into the middle of the chest, and I biopsy all these lymph nodes. One of the problems with mediastinoscopy is that you could injure this nerve here, left recurrent laryngeal nerve. And so then what happens is if I injure this, or if I even traction injury, it can cause hoarseness. And so then, but with video, you're able to see things really clearly. And so you could take literally not just biopsying the lymph node, but actually removing it. So I'm technically doing a lymphadenectomy, or that's what I try to do. That's my goal whenever I do mediastinoscopies, so that you could get as much tissue. And I could also cauterize. There's the nerve. There's some feeding vessels that I could cauterize it. We were taught never to cauterize in this area, but I do. So again, we talked about anatomic lung resections. Most lung cancers require lobectomy, but there are studies that are coming out now stating that segmentectomy could be equivalent to lobectomies. But I think it's really important where the lesions are. If this lesion was here, involving this artery and vein from the upper lobe and the lower lobe, or the middle lobe, then I would say that segmentectomy may not be a good option. Or if this lesion is just closer here, where I have to make sure I get a good margin, where I disrupt the artery and the vein to the area, if I cut either the vein or the artery, that area, that segment that's involved becomes useless. Because why? Arteries supplying deoxygenated blood into the lungs, and then there's the airway oxygen exchange with carbon dioxide, and then goes back to the pulmonary vein. So if I cut the artery, but I still have the lung tissue, that lung tissue is not doing anything. You may still get air in it, but there's no oxygen exchange. And then here's a little tool that indocyanine green is a radiofluorescence. And so it actually, once I cut the artery, then we inject this immunofluorescence fluorescent dye in. The fluorescent dye is not going to go where the artery is cut. So where it's going in, that's from the and this was a lingular segmentectomy. So what I did was injected, and this is the upper lobe. But what I did was, instead of just cutting right here, I just wanted to make sure I have good margin, so I kind of cheated and went up a little more. And you could see there's not really a good fissure either. And so this is the way to kind of determine how to do a segmentectomy even without the fissure guidelines. And between the lobes, you're not going to have fissures. And so this will tell us where to cut. And so this is really interesting. So wedge resections. What is a wedge resection? Here's a lesion. This was a metastatic lesion, but I use it as a purpose because it has a nice wedge. So I always want to have at least, 5 millimeters to 1 centimeter, ideally 1 centimeter margin, but sometimes you can't. And so I cut around it so that you have good margins. Okay, so that's a wedge resection. So before we go to the esophageal cancer, what criteria do I use to determine if the patient is a surgical candidate or not? Obviously, I think surgery is the best. I'm not biased, but not everyone can get surgery. So when someone smokes, every time you smoke a cigarette, you're causing damage to your lungs. You could, and actually, that's a good question that I didn't mention is in this picture, you could actually see this area. This is emphysema. What is an emphysema? Well, it's dilated alveoli. So alveoli, where's my pretty picture that I drew? Alveoli are, just imagine little sacks of balloons, okay, that are connected. Actually, they're in the market where you could, the water balloons where it has multiple balloons attached. Just imagine like that, where you use one tube to blow in, and it's gonna inflate all those balloons. Well, with smoking, what it does is it actually damages the lung itself and the elasticity, being able to contract. And so it dilates and then dilates and dilates and just gets bigger and bigger. So then what happens is you could see in this patient that you have normal, I mean, it's not perfectly normal, but has almost normal lung tissue, but has all these areas that are dilated. So why is that important? Well, this patient's lung here is kind of useless because it's not really doing that oxygen carbon dioxide exchange. Okay, like here, this portion of the lung, you can see that this is all emphysematous. I mean, there's minimal oxygen carbon dioxide exchange, and so air is going in, but it's not doing its job. So, what if the lung cancer was here? So I'm taking not just, I'm leaving this bad lung that's useless, but I'm cutting this good lung. So that's why lung function test is crucial to determine if how much lung that we can remove. And that's one of the things. Number two is I do not want patients to be pulmonary crippled. That's a really bad way to live, meaning having air hunger, not being able to breathe. Not just imagine you run. I hate running, so I don't know why people run, but to each their own. But when you run like a mile or a half mile, you get really short breaths. Just imagine living like that, that air hunger. The quality of life is going to be really bad. I do not want that on them, on any patients. And so then what I do is look at the lung function test. But if they require oxygen at home, I'm not going to make it any better, but I'm just going to make it worse. So if the air hunger goes away with 1 or 2 liters per minute on ambulation, yeah, there's a little more wiggle room, but really, really small wiggle room. And a lot of times by the time they require oxygen, their life expectancy is kind of determined by the COPD, not the lung cancer a lot of times. So that's one. Number two is cardiac wise. Whenever I tell patients heart, let's see so here's the heart, all right? Heart, we have to think of it as 2 different pumps. One pump that supplies all the blood into the entire body. That's the oxygenated blood. But the second pump brings all the blood in and it gives to the lung so they can be oxygenated. So now you have effectively two pumps. Number one, we got to make sure the patient's able to tolerate surgery. The last thing I want to do is have them have a heart attack. And so make sure that they don't have coronary disease. If they do, have to get a stress test and most people say clearance, but it's actually risk stratification. The one can predict if the patient is going to have a heart attack or not, but increases the odds that they probably won't if they pass the stress test. One of the things that I do when it comes to stress tests is actually have them walk upstairs to about 4 floors, 1st to 5th floor. Some patients, they were just kind of talking the whole way up. Yeah, they may be short of breath, but they're going to tolerate. They need to have a surgery. But there are patients who just one flight, not even a floor, but half a floor, 1 floor, they're already out of breath and they can't breathe. And are they going to tolerate a lobectomy? They may tolerate a segmentectomy, but a lot of, and so, all those data I have to make sure that patient's gonna able to tolerate. And so those are the big two things. And of course, mobility is a big thing. If you don't walk, then you could get a pneumonia. And if you do, then there's a good chance that you can die because you're not clearing out, being able to effectively clear out. And so sometimes it's really difficult in COPD patients because they're not really clearing out the secretions really well. So yeah, that's the kind of the basic of the criteria. Of course, I always look at the patients and see what they look like. If they live by themselves psychosocially, do they have good family support? If I'm gonna do a major lobectomy, like left upper lobectomy, and it's 25% of the lung, and if they live by themselves, far away from anyone, medical care, I have to be careful because even if they do well after surgery, are they gonna be able to, they're still gonna be pain, they're gonna be able to have some shortness of breath, and they're gonna get tired easily because it's major stress on your body. Then how are they gonna deal with that? Are they gonna be able to recover at home by themselves? And I have to actually look at that as well. One of the interesting thing, because I kind of spoke too fast earlier, thinking that I had to be done in like 45 minutes, is arrhythmia. Arrhythmia can occur with any lung surgeries. Why? I said 2 pumps before. So imagine the right side of the heart is pumping 5 different pipes. And so when you have a water pump, you're pushing the water in through 5 pipes, and all of a sudden you close 1 pipe. Then what happens? The motor will all of a sudden surge, give more power, need more power to kind of push through the resistance, but then it gets better. When that happens, right heart does the same thing. And so when it does that, when it gets stressed, the right heart's kind of sensitive. And so then you could have increased risk of atrial fibrillation. So that's actually a little bit, but that was always interesting. And so, but I always tell the patients that can happen as well. And of course, if someone had atrial fibrillation already, then they're probably going to go into atrial fibrillation again. So esophageal cancers, from the previous presentation, that it's not as common as lung cancer. And we do see not too many esophageal cancers here, especially for surgery, esophageal cancer surgery. You don't want to do it when it's later stage. They don't do as well. And so if it's metastatic, definitely don't want to do it because it's not going to improve outcome. Why is that? I'm going to show you, I'm going to explain why later. But you could see the anatomy. Here's the esophagus and here's the stomach. And so most of the cancers that we see in America are on the G junction, but lower third of the esophagus. And we see mostly adenocarcinomas, and it's associated with reflux and things like that. But in other countries, in Asia, for example, you could have a lot of esophageal and squamous cancers and squamous cell carcinomas. And we don't see that as often, but it can be sometimes it's really bad. And if you have cancers up here in the proximal third, it becomes a really, really difficult thing to treat. So how do you diagnose stage esophageal cancers? So one interesting thing about esophageal cancers, there are 2 different types, like I mentioned, adenocarcinoma and squamous cell carcinomas. Right? Squamous cell carcinoma associated with alcohol and smoking, especially smoking. You could develop squamous. And so the staging itself, or characterization of the tumor and the lymph nodes for both squamous and adenocarcinoma is the same. Okay? And the lymph nodes, how in the lung cancer, we're looking at the regional node or segmental nodes, bronchial nodes, and then you go into the mediastinal node. For esophagus, it's still based on the number of nodes. If you have 1 or 2 regional lymph nodes, it's N1. 3 to 6 is N2. 7 or more regional lymph nodes is N3. What is the problem with this lymph node? Is that it's kind of difficult, and I'll mention that later. But the important thing about this is squamous cell carcinoma and esophageal carcinoma. If you look at the squamous cell carcinoma, so like say stage 2, T2, N0 is stage 2, or T3, N0 is still stage 2. But adenocarcinoma is T1, N1, stage 2A. T2 is 2B, but if they're, and here, stage T2, N1 could still be stage 2. And for adeno, if it's T2, N1, it becomes stage 3. And so there, the staging, actual staging itself changes depending on squamous cell carcinomas and esophageal carcinomas. And so it's really important to make sure you look at this and make sure that the programs in the computer EMR is correct as well. And so, you know, there's, what was that? I wrote it down, all those little differences. Where is it? And it can get kind of confusing, right? And so T1 and 1 is 2B for squamous, but T1 and 1 for pathologic staging is different. What is that? Oh, what is pathologic staging and clinical staging? Clinical staging is when you stage the patients before surgery without actual formal resection. Pathologic staging is when you do the surgery, formal surgery, esophageal lung cancer or any other cancer. When actually, and you're looking at the specimen and looking at the lymph nodes, that's when you could say the pathologic staging. So one question was, you know, that I had before in training was, okay, well, mediastinoscopy, technically you're actually getting a good staging because you're kind of doing surgery, but no, that's still as a clinical stage because you're not actually looking at the tumor itself. It makes sense because you could have, you know, endocarcinomas, but you could have multiple carcinomas, you could have separate things. And so that's really important to know. So lymph nodes, it depends on where the tumor is. So here is in the mid-thoracic esophagus. A lot of times these are squamous carcinomas. Lymph nodes can be all the way here. Okay? And not as common around the stomach. But if the tumor is around the G junction, what's going to happen? It's going to be more likely kind of in the abdomen. Okay. And you know how I mentioned that for lung cancer, lymph node status depends on where the lymph nodes are located. But for esophageal cancers, it's number of lymph nodes. And so how do you determine that? Well, one, by looking at PET scan, CT scan, any large nodes, but then you also have to get tissue diagnosis and EUS or esophageal ultrasound. But are you going to look at all these lymph nodes and are you going to biopsy all those lymph nodes? So it's not actually a perfect tool when it comes to lymph nodes. The problem is, you know, it doesn't matter if you have N2 or N3. Yes, staging wise, it may not be as more advanced, but if you look at the staging for endocarcinoma, if you have any nodal disease, already becomes stage 3, rather than I guess T1, N1. But even then, if you have N1 disease, most of the time you're not gonna do. It's already more advanced, not metastatic, but it's just, you know, it's not gonna, the patient's not gonna do as well. And then pathologically, so when we do surgeries, we try to take as many lymph nodes as possible. And the stage goes from clinical T1N1, goes from 2A to 2B. So pathologic staging will let us know what the tumor is. I mean, that's going to be the best way to stage. But of course, can everyone get esophagectomies? No. Why? Because it's a quite morbid of a procedure, in a sense that it actually changes your life. And I'll talk about that later when we talk about the procedures. So one of the things is the C-word classification. What is a C-word classification? So we know that if it's in the esophagus, way above the G junction, then it's easy. It's esophageal cancer. If it's in the stomach, yes, it's stomach. But in this area, is it truly gastric or esophageal? It becomes somewhat different because the neoadjuvant therapy for esophageal cancer and gastric cancer, I guess I didn't add that slide because I figured there's going to be too many, is that neoadjuvant, you get chemoradiation for esophageal cancer, but you only get chemotherapy for gastric cancer. And so what they've developed is kind of the classification where, let's say 1 centimeter over the anatomic BG junction, and then 2 centimeters below, that should be C-word 2, and treat that as esophageal cancer. But if it's beyond 2 centimeters, epicenter of the tumor, middle of the tumor itself, where it started, is way down here, but it can invade up here. The surgery becomes different too, because if it's gastric, the question becomes, do you do total gastrectomy, or do you do gastroesophageal resection or esophagectomy? And so that's really important to know by the surgeons, endoscopists, and the oncologists to see how we're going to treat these patients neoadjuvantly, because most of these patients are not going to be in situ disease or early stage disease. They're going to have, a lot of times, have nodal disease. And so it's really important that the multidisciplinary team discusses what will be the best treatment, how it's behaving. If I see tons of lymph nodes down here, I don't see any lymph nodes. And the tumor, even though the epicenter looks like it's here, but it's extending this way, is that more gastric? We always have a discussion during these cases. How should we optimally treat these patients? So you could see, so they always go into the duodenum, they come back. But what they're doing is with the, you could see the Barrett's or changes. So here's the esophagus, middle third. This patient had Barrett's all the way up to the middle third. But what you can see is kind of the salmon color changes and becoming squamous to adeno. So in the esophagus is squamous, then it becomes secreting cells. And so then what happens is when this thing creeps up all the way and kind of mucosa, it replaces a squamous cell, then you're starting to get Barrett's changes. But whenever these changes are happening, these are not supposed, it's not supposed to be there. So then what happens is there's high risk that it can become cancers. And you could see the changes and difference and how the mucosa, and this patient had cryotherapy or freezing of this lesion. And so then the area, and so you see these kind of scarring tissue. So here's patient had this tumor here, and when they looked at it, they actually saw a lymph node that are enlarged, and so called that a T1 patient or N1 patient. Got neoadjuvant chemo radiation, and then we took it for surgery. And but he had multiple Barrett's, but this thing kind of formed. And this patient's cancer was actually very early stage. And so, you know how like people were talking about the intramucosal. Oh, did I add that? Oh, I guess I forgot to add that slide. Is the mucosal involvement? Is that in situ? What layer is it? And I don't know what happened to that slide. Oh, I made it too. But important thing is, is that within the basement membrane? Is it going through? Is that going to the muscular layers, propria, laminar propria? All those layers, different layers. You can see all these different layers, and so unless there's obvious that it's within the superficial layer, a lot of times it goes beyond, and so then what happens is, in order to treat it, you have to do an esophagectomy. But of course, if it's just in the mucosa, could you do an endomucosal resection? Yes, you can. But how often do we see that? Not often. So what are the types of surgeries? So here, let me go to this one. So there are 3 types of esophagectomies that we always kind of talk about. Transhiatal, meaning make an incision here and make a at the neck and make an incision at the upper abdomen. And then what we do is we cut the stomach about here, at least 5 centimeters from the tumor, and we tuberize it, meaning making a tube out of it. And then we're pulling this and attaching to wherever we cut the esophagus. So transhiatal is when we make a cut here, and then we dissect with our hand all the way to the neck. And then from the neck incision, we meet and dissect around the esophagus. And then we pull the esophagus, divide it, take the specimen out, and then putting the tube back up into the neck and anastomosing. And so there are a lot of cases that are being done this way. I kind of don't like that. The reason being is because the lymph nodes, right? Yes, even if it's a G junction cancer, there's a increase, not that big of a chance that there could be lymph nodes, but I'm gonna get all these lymph nodes. If you do the transhiatal, you're not gonna get any of the lymph nodes in the chest. You're gonna get lymph nodes around the stomach, the celiac arteries, and other lymph nodes, but you're not gonna get any of the lymph nodes in the chest. Then Ivor-Lewis. Ivor-Lewis is, instead of transhiatal, making the incision in the neck, you're actually making the anastomosis in the middle of the chest. So classically, non-minimally invasive, for example, is when you tuberize the esophagus, get it ready, you pull it up, make a thoracotomy, and you attach it. Good thing about Ivor-Lewis is that the lymph nodes or on the esophagus, peritracheal, paraesophageal lymph nodes are taken. And this can be done robotically or minimally invasive, laparoscopic or robotically and thoracoscopically. Okay. Then the third way is my counter, the 3-field, kind of like anastomosing the esophagus and the new esophagus all the way up in the neck. But what you do is you mobilize the esophagus in the chest. And so this is what this picture is. So what I do, that's the procedure that I like. Why? Because I could get good lymphadenectomy. And the reason why I don't like the Ivor-Lewis is that if there's a leak here, we could always open this wound and it's easy to control. But if there's a leak here, you could get this thing called mediastinitis, and that can be really, really bad. And people can die from it. And on top of that, oncologically, and studies shown that it doesn't really matter. But the thing that I don't like is the lymph nodes, especially the G junction or even just the esophageal. The lymph nodes likes to travel along the length of the esophagus. So if I come here, it's negative marginal frozen section, but how far is it from actually here? Are we getting any of the row cancer cells up here? So we're definitely taking more of the esophagus. And you could see that esophagus has been mobilized, and it's actually, I'm making a dissection all the way into the neck, and the esophagus itself, and I place a Penrose drain around it, and then I push it up. So then when we're dissecting the neck, we could actually find that and just pull it. And even if I do this, and if there's metastatic disease in the abdomen, the esophagus usually survives. I mean, this looks a little beat up, but the vascular supply, the blood vessels are actually coming along the esophagus as well. And so esophagus will survive. And so you could always abort as well. And then what is the substernal esophagectomy? Well, substernal esophagectomy is when a lot of times we end up doing it because we have to, if there's a major leak and we have to go and try to fix it, put a stent in, it's not working. And now we have to kind of separate the two, bring the esophagus out of the neck, kind of as a drain, because anytime you swallow saliva, you don't want it to have a pouch sitting there. And then you have the neoesophagus in the abdomen, but it's kind of stuck in the chest. So sometimes we bring it down. Well, we don't do this often, but when we do, we try to make it easier so then we could reconnect the patient once patient recovers from the leak and on the subsequent infection, and the just to recover from the trauma that patient has gone through. And so then what we do is then how are we going to reconnect it? Well, you could actually go on, the area in the middle of the chest is going to be socked in because of the all the infection, inflammation. And so you're not going to be able to bring the esophagus through that area. And so then what we have to do is we have to bring the esophagus underneath the sternum and reattach it here. And so you could see this patient had a esophagus that went underneath the sternum. So, and then important thing about question, one of the questions that I received was, how do I use cancer data in my practice? Well, that's really important within the cancer committee as well to make sure that we're meeting the guidelines and we're doing what we're supposed to be doing oncologically. But it's really important to kind of give us an idea how we are doing. Without it, we're not going to be able to implement our quality improvement initiatives or studies. We're not going to know. The more data we have, the better we are going to be at making sure that what we're doing, the processes, how the patients are being referred. If the patient is being referred from PCP to us or GI or oncology, and why is there a month wait? Is there a way that we need to change, or is there a kink in the process where we have to make it better? Why is the GI taking 3-4 weeks to do EGD when patient needs? And so all that data points are really, really important for us. And so that's the biggest thing that we do with the data that you guys collect and you guys help manage. And we can't do that without you guys. So I know that kind of went fast initially, thinking I was supposed to be done by 11 or 12. Okay. Any questions?
Juliet, do you see any questions?
I do not. Thank you so much, Dr. Baik, for answering as we've been. And feel free to, if you guys have questions after this presentation, send them to me and I can always pass them along as well. And thank you to those who submitted questions prior to the presentation also.
Yep, and yeah, thanks for submitting those questions, and thanks for getting all the questions, Juliet. Because you know, a lot of times these can be very, you know, the subtle things, or kind of sometimes the details can be very confusing, and it's always better to ask. And I know I kind of spoke kind of fast, so. But if there are anything else that you need to clarify, I'd be happy to do that as well, even if you don't have any questions per se.
A lot of feedback thanking you for how informative your presentation has been, and I just want to show that as well. Really appreciate you taking the time to break down some of those surgical procedures for us and some of the staging questions that we have, because I know it can be very challenging sometimes.
Mm-hmm. And it's like, it's important to talk to the surgeon. You know, I mean, I know some cardiothoracic surgeons are not the nicest, or because they're so busy, or maybe that's the excuse. But you know, most important thing is that we have to help each other. And if you have any questions or issues, you just ask and try to help. And so, and even if we, you know, some other questions, you may be able to get someone to kind of ask the right person and get the information. So it's better to get the correct information than, because what, you know, like AI, artificial intelligence, I'm not smart enough to do the artificial intelligence, what the heck is going on, all this chat GPT, all these algorithms. But what is the most important thing about AI or any type of new, you know, machine learning is the data that we have within the system. And so if you have poor data, what's going to happen? You're going to get poor results or misguided results or recommendations. And so it's really important to have the correct data so that we could get the best outcome.
Absolutely. And thank you again for sharing your time with us this morning. We really appreciate it.
Oh, yeah, I'd be happy to help as much as I can. I'm glad that thanks for giving me the opportunity to talk about this, because you know, it's very interesting and fun stuff.
It definitely is. Well, if there are no further questions, and I don't see any, then we will move on to the last portion of today's workshop, which is going to be going over some actual lung and esophagus cases. So give me one moment and I will share my screen again. And these are, you should be able to see my slides, correct?
Yeah, we do see them.
Perfect. These are real actual cases that we have in our ACR database. And I just pulled them at random. Obviously, any patient identifying information has been changed, but I just thought it would be good to go through a few case scenarios with the time that we have remaining. So here are our objectives for this morning, and we are now going to practice some coding scenarios on actual lung and esophagus cases. And please feel free to continue to submit your questions as we review these cases, because if there are questions, we'll do a formal Q&A afterwards and get to as many of them as we can. And also, I did share the link for the evaluation for today's session in the chat. We do ask that you give us your feedback on today's presentations. It really does help us to determine future educational goals for workshops like these. So thank you in advance for clicking on that link and giving us your feedback. So here are our esophagus cases. First, I just wanted to say that unless I otherwise specify in my slides, the solid tumor rules we're going to use are most likely going to be M2, which is abstract single primary when there's a single tumor, and I've got the notes there beneath the multiple primary rule because I feel like sometimes we just look at the rule and we forget to read through the notes afterwards, and they can be very helpful. For instance, the first note is pretty straightforward, single tumor, always single primary. And then it goes into information for us, like that tumor may have in situ and invasive components, and the tumor may have 2 or more histologic components. That doesn't change our number of primaries for how many abstracts we create. And then H12 is going to be the histology rule that I use most often for these cases as we're going through them for esophagus. Code the histology when only one histology is present. Don't code terms that don't appear in the histology description, and use the appropriate tables. As we know, those other site rules for the solid tumor rules were revised for cases 2023 and forward. So we have those wonderful tables for each of the subsites in the other sites rules that we can go to and see some of those most common histologies for esophagus. And that would be in tables 3 through 23, and there's a link in the solid tumor rules. So here is our first case. We have a 72-year-old male who presented with the chief complaint of dysphagia and suspected reflux, history of heartburn for approximately 1.5 to 2 months, no prior history of GERD, gastroesophageal reflux disease. The patient endorses decreased appetite and weight loss. His physical exam was within normal limits, and the recommendation was for concurrent chemoradiation. Oh, okay. Let me see if I can switch that around so you guys can hear me more clearly. Just a moment. And let's see if that's any better.
That's better.
Thank you, Georgia. The recommendation was for concurrent chemoradiation with weekly carboplatin and paclitaxel, and then on to surgery. And then following that physical exam, the patient was seen about 10 days later in the ER with epigastric abdominal pain, fasciculations, which I actually had to look up, and that is muscle tremors and spasms of the esophagus. The patient had difficulty swallowing, and the patient ultimately passed away during that hospitalization before any of that treatment plan could be initiated. So as we know, that's going to be important later. And the patient did have an upper GI endoscopy. There was one benign appearing lymph node and moderate stenosis at the GE junction, gastroesophageal junction. They had grade C acute esophagitis with some bleeding in the lower third of the esophagus. The stomach cardia and the gastric fundus were normal, and there was no ulceration or bleeding in the entire examined stomach, the duodenal bulb, and the second portion of the duodenum. Then a few weeks later, they had another upper endoscopic ultrasound, and the physician staged this patient as a T3 N2 MX. They had a large fungating mass with no bleeding in the lower third of the esophagus, located at 34 to 38 centimeters from the incisors. The mass was partially obstructing and circumferential, and the ultrasound suggested invasion into the muscularis propria, level 4 adventitia. There were 2 malignant appearing lymph nodes in the lower paraesophageal mediastinum at level 8L, and the largest lymph node was 12 millimeters. It was round and it had well-defined margins. And then we do have some lab values. They found that the patient had a normal expression of MLH1, MSH2, MSH6, and PMS2. And those are all of our markers for Lynch syndrome. And they also did a HER2 test on this patient, which came back as equivocal. And then they did have a PET CT There's an upper metabolic distal esophageal lesion from their known malignancy. There was a prominent uptake to this lesion, and the physician state that it may interfere with evaluation of any subtle periesophageal nodal disease because of the uptake right at the place where that lesion was. They did a biopsy and it came back poorly differentiated adenocarcinoma arising in Barrett's esophagus with high-grade dysplasia. And they also did a biopsy of the stomach, which had no significant findings related to their cancer. And the patient did not have any evidence of H. pylori. Treatment, we have no treatment here because the patient expired prior to the planned surgery. So let's see how we would code that case. The date of diagnosis is going to be May 14th, which is the date of that biopsy. Pretty straightforward. Here's our primary site, that distal esophagus. There's no laterality to code for esophagus. It's not a paired organ. We only have one of those. The histology gets coded to 8143, which is adenocarcinoma. The clinical grade is 3, poorly differentiated on that biopsy. And we do not have a pathological grade on this tumor because the patient did not go on to have any surgical resection. And the only other way that we could code a pathological grade would be histologic proof of distant metastases, and we don't have that in this case. So we're going to code that to 9 or unknown. Lymphovascular invasion is a 9 because we have to get that off the pathology report, and we do not have any statement of that from the pathologist. HER2 overall summary, we don't have that in our record. No nodes were examined or positive, and we would stage this case as regional by extension and by lymph node involvement because of the invasion into the adventitia, and also because of those lymph nodes which were suspicious on imaging. And they did have a diagnostic staging procedure, so we're going to code that to O2 because there was a biopsy of the primary site on the 14th of May, 2023. That's when that patient was diagnosed. No surgery. The chemotherapy code is going to be 85 because it was recommended in that treatment plan, but we do not have chemotherapy in this case because the patient passed away prior to initiation of treatment. No hormone, no immunotherapy, no transplant, no other treatment. We do not have any surgery to regional lymph nodes. We do not have any surgery to distant sites or regional sites. No palliative procedures because the patient was unable to have any treatment. Surgical approach is going to be blank because the patient didn't get surgery, and the margins will be 8 because the patient did not have surgery. No treatment in this case. So the date of first course treatment will be blank, same with the date of the most definitive surgery. Reason for no surgery is 5 because the patient passed away. Surgery radiation sequence is going to be 0 because the patient didn't have radiation or surgery. And the reason for no radiation is 5 as well because it was recommended that the patient undergo preoperative treatment, but the patient did not end up having the treatment according to the plan. No surgery or systemic treatment, so we leave that as a 0. All of our radiation codes are going to be 0s because that patient did not have any radiation. And that is our first case. Let me go ahead and skip ahead and we'll do one
Dr.
case.
Baik, go ahead and comment if you feel the need to comment, please.
Can you go back to the case description?
Absolutely.
Because they're calling it N3. Sorry, I know a lot of clicks
You're
there.
fine.
One more. And then so adventitia, right? Okay, go down, adventitia. So T3 is fine, but it's N2. N2 is 3 to 6 regional nodes. And he mentioned 2.
Mhm.
Isn't
So that would
N1?
actually be an N1.
1.
You know,
Number
and
2.
that's interesting because sometimes we do see where the MDs, the doctor staged a certain way, and then we review the record and we have some discrepancies in the information. So that's,
Uh-huh.
yeah,
So that's important to kind of clarify, right?
right.
Why there's the discrepancy. There's only 2 mention of 2, and PET scan. If the PET scan showed multiple other lymph nodes, fine, but it didn't say anything about other lymph nodes. Then and so you have. I know that I've reviewed the quality metrics, and I get papers that I have to review cases, then I do, but that's really important, and these may be the cases that where it may be flagged to be reviewed so that we get the correct information in. Otherwise, I mean, this patient passed away, so does it really matter? No, but it does matter when it comes to overall data, like I mentioned with the AI, right? And then with the fasciculations, the thing that I don't know if you guys have ever seen, the muscle fibers kind of twitching. Have you ever seen that video? Maybe I should share it. But that's what it is. That's here. I could while you guys are presenting, I could find it. But yeah, that's really important that we get the correct information in. And I'm actually surprised that they didn't biopsy any of the other lymph nodes. And that could be because the mass itself was fungating and it was not safe to do so. Maybe it was the how to get to the node. Maybe they saw it, but they couldn't biopsy it. But it's always better to have biopsy than not biopsy proven lymph node involvement. And of course, having this patient, it's a fungating large mass, and so. And I'm actually surprised that it's partially obstructing, but it's sad that this patient passed away. But if it's fasciculations, I mean, how does he die? Well, could it be aspiration? If it's aspiration, then is it better to have patient? It depends on. It says partial obstruction. What is a partial obstruction? Is it 80%, 90% obstructed? Well, I guess then they're gonna call it nearly obstructing. But is that above 90 or 80, or is that only like 30%? And so that's important as well, because then, well, the patient could have benefit from G-tube, for example. But then, of course, if you put a G-tube, surgery may not be possible. But that's not really the case. We could always kind of go around that as long as where they place it. But things like that are important, or having a jejunostomy placed pre-op.
Juliet, there's a comment about her too.
Yes, I did see that. Thank you, Valerie, for pointing that out. I will take another look at it after the presentation and make an update once I've had a chance to take a look at those codes. But thank you for pointing that out. And thank you, Dr. Baik, for that comment about the staging as well. And what we would instruct folks to do is to take a look at how those physicians have staged it, to ask for clarification if needed. Maybe there's something that we're not seeing in the medical record that would justify how they're staging it, to acknowledge that the provider has staged it a certain way, and then to make any staging adjustments and justify that in our text staging area of our abstracts, so that we note that yes, it was staged this way, but the stage should be N3 or N1 for whatever our justified reason is, the number of lymph nodes in this case. So that's how we would handle that. Any other questions about this case? I don't see any. So let's take a look. And you guys do have, I don't think we're going to get through all of the cases but you do have the cases and the rest of my slides. So feel free after this workshop to look at the rest. I have tried to go ahead and give all of the answers in there as well, so you should have them in your slides, and I'll send out any corrections after today's presentation. Let's do one more esophagus case and then maybe look at a lung case. So this is another esophagus. We have a 65-year-old male who presented for a radiation oncology consult, recently diagnosed on biopsy with proven squamous cell carcinoma of the thoracic esophagus. The outside endoscopic ultrasound staging was stage 3, T3, and 1. The patient's mother has a history of rectal cancer, and the patient has a paternal uncle with melanoma. The physical exam was within normal limits, and the plan was for chemoradiation. The patient indicated that they had no desire to proceed with surgical intervention. The patient had an upper GI endoscopy with biopsies of a medium-sized ulcerated mass-like, partially obstructing, partially circumferential. And here we actually have a statement that this mass involved 1/3 of the lumen circumference. So we know how much of that circumference was involved. Lesion was slight oozing in the upper third of the esophagus. This mass extended 21 to 24 centimeters from the incisors. It was striped, and there was some mild erythema in the mucosa in that pre-pyloric region of the stomach. And they did take a biopsy. There were a few small sessile polyps in the gastric body with polyp removals, and the examined duodenum was normal. They had another upper endoscopy on June 7th, 2023. Ulcerated mass with associated stricture located 25 centimeters from the incisors. The stricture could not be traversed with the endoscope, and thereby that resulted in incomplete evaluation. But they do note at least T3 and 1 by endoscopic criteria. And HER2 was not ordered or performed. They had an intensely FDG avid soft tissue thickening involving the proximal third of the esophagus, most consistent with biopsy-proven squamous cell carcinoma. No evidence of FDG avid nodal or distant metastatic disease, and they did have a chest x-ray, which was negative. So nothing is pointing at distant metastases. They had that biopsy, which is consistent with squamous cell carcinoma. No HER2 was done. The stomach was biopsied, and there was some nonspecific chronic inflammation. And those polyps, again, just had reactive hyperplasia, but no indication of cancer cells in the stomach. So this patient did have radiation, proton beam radiation, and you can see the dose was 5,000 centigrades with 200 centigrades being delivered per fraction, 25 fractions to the proximal thoracic esophagus and the regional lymph nodes. And then the patient completed chemotherapy, which consisted of carboplatin and paclitaxel given alongside that radiation. So let's look at coding for this case. We have 5/20/2023 as the date of diagnosis. And you'll see that in this case, we do have another site-specific factor, which is that esophagus EGD epicenter. And that is a site-specific factor that only applies to squamous cell and not to the adenocarcinomas. So that's why we have that to code for this case where we didn't for the last one. We've got C15.1. This is in the thoracic esophagus. No laterality because it's not a paired site. This is a squamous cell, so our histology is 8070/3. The clinical grade is a 2, and the pathological grade is a 9 because, again, this patient did not have a resection that would qualify them for pathologic grade. Lymph-vascular involvement is 9. The HER2 was not done, so 9 is correct in this case. The esophagus EGD epicenter is a 0. This is an esophageal cancer rather than a stomach cancer. No lymph nodes were examined. This case also regional by direct extension and lymph node involvement. And they did have that biopsy on May 20th. No surgery. They did receive chemotherapy with multiple agents. So that's coded to a 03, and there's the start date for your chemo. No hormone, no immunotherapy, no transplant, no other therapy, no lymph node surgery, no surgery to other sites, no palliative treatment, and no surgical approach. So your surgical margins will be 8. For no surgery, treatment was given. So our treatment summary status here is M1. That date of first course of treatment is going to be the date that chemotherapy and radiation were administered. The date of the most definitive surgery is blank because the date did not receive surgery.
Juliet, can I stop you?
Oh, yes.
We're hearing that background buzzing noise again.
Let me try switching my microphone again and seeing.
Oh, that's better right there. We don't hear the buzzing.
Okay, thank you, Georgia. They did not have surgery, so we would code the radiation surgery sequence to 0. Radiation was actually given, so that should be a 0 for performed. They did not have surgery, so we would leave surgery systemic sequence as 0. They received proton beam radiation, the esophagus, and those thoracic lymph nodes, so that you would code primary treatment volume and the location of the radiation. It was intensity modulated and 200 centigrays per fraction over 25 fractions for a total dose of 5,000 centigrays. And that was all in one phase. So phase 1 radiation would be coded. Radiation treatment administered as planned. And the total dose is 5,000 centigrays. And there's your date for start and end for that radiation. And I think we have time for one more case.
Dr. Baik, were you going to show us something? Just making sure. We can't hear you right now.
Yeah, sorry. Here, let me share this. I'm just gonna show the, share is disabled.
There you go, Dr. Baik. You should be able to share now.
So I found this video online. Where is it? Hey, what happened to it? Oh, I don't know what happened to it. Okay, well, let me stop sharing. I don't know what happens to the video. But the important thing about esophageal, why the patient not want surgery. That's really important to know because esophageal surgery is a life-altering surgery, meaning you're not going to be able to lie flat, supine, to sleep anymore. You have to have your head elevated at least 30 degrees. You have to eat small meals, initially liquid and full liquid and mashed. It may take up to 3-6 months before you could eat anything solid. You may not be able to eat steaks for at least a year. You have to walk after eating. You have to not eat at least 2 hours before because you could have reflux because the G junction is gone. And so it's a really important thing that you have to know that surgery is really, really difficult on the patients.
Can you resume? I'm curious. Normal exercise? Oh, you're muted.
Sorry. Oh, I found it. There's the fasciculation of the muscles. You see how the muscles are all twitching?
Yeah.
So, but normal exercise, but it's not the normal exercise issue. It's the anatomy, right? When you have the esophagus up in your chest or your neck, bile and stomach, the acid is not supposed to be produced because the vagus is nervous tip, but you're still gonna produce some acid. And then you got the bile acids. That's gonna travel. There's no, it's just open conduit. So it's gonna flow through the easiest way possible, right? And so when you're lying flat, when you have esophagus now, without the GE junction, now it's gonna go up. And so you could actually have increased risk of aspiration and having really bad pneumonias. And if you have chronic aspirations, you could have pulmonary fibrosis as well.
Interesting.
Yeah.
Interesting. Juliet, I think you can go on to your last case.
Sure thing. Let me just go ahead and share my screen again. And you should see lung on the screen.
We see it.
All right. So we have a 54-year-old female patient seen for a recent diagnosis of lung cancer. The initial presentation was on imaging for a recent episode of bronchitis. The patient endorses a mild daily cough with white phlegm, shortness of breath on exertion, and occasional wheezing. The patient is a current everyday smoker. The physical exam was within normal limits, and the plan was for surgery in this case. The patient did have a couple of bronchoscopies, and lab values on that first bronchoscopy on July 5th, 2023 showed that this tumor is EGFR and ALK negative. And about a month later, they did another bronchoscopy. There were no lesions. The mucosal surfaces were normal with normal secretions, and a biopsy of the left lower lobe nodule was performed. The endoscopic bronchial ultrasound was used for a biopsy of those lymph nodes in stations 4R, 7, 4L, and 11L, and this was done with no complications. Here's the imaging findings. The patient did have a chest CT, and there was a nodule in the left lower lobe of the lung, which measured 27 millimeters, and it was indeterminate on imaging. Malignancy needs to be excluded, and a biopsy was recommended. Then 4 days later, they did a PET CT, and there was an intensely tracer-avid solid lung nodule in the left lower lobe of the lung, which measured 2.8 centimeters. It was faintly avid, normal in size, mediastinal lymph nodes, and there was no evidence of distant metastases. They did do an MRI of the brain, which was negative for any definite sign of intracranial metastases. And then here's the pathology report for this case. They did a biopsy of the left lung lower lobe, which was positive for squamous cell carcinoma, and nodes were all negative for metastatic disease. Then they did a robotic assisted lobectomy with a mediastinal lymph node dissection. And in the left lower lobe, there was an invasive squamous cell carcinoma with single focus, and it measured 3 centimeters. It was moderately differentiated, or grade 2. The spread through airspace was not identified, or STAS is the abbreviation that I've seen some physicians using for that. Visceral pleural invasion was not identified. There was no direct invasion of adjacent structures. Lymphovascular involvement was not identified. The margins were negative. 0 of 20 lymph nodes were positive. So the pathologist staged this as a PT2A EN0. And the only treatment in this case was that surgery, a robotic assisted lobectomy, and the mediastinal lymph node dissection in this case. So we have the date of diagnosis as July 5th, and I believe that's the date of biopsy. Primary site is that lower lung. We do have 2 lungs, so we have code laterality here, and that's going to be left. Histology is 8070/3, invasive squamous cell carcinoma. We don't really have a clinical grade in this case, but we do have a pathological grade, grade 2 for this tumor. No lymphovascular involvement, no separate tumor nodules, and pleural invasion was not identified. And we do have that lobectomy to be able to code that. No ALK rearrangement and EGFR was not identified. We do have those values, so we can code those two data items. They examined 20 lymph nodes, all of which were negative for lung cancer. And this is going to be localized. We don't have any evidence of spread. We don't have any evidence of pleural invasion that would keep staging up. They did have that biopsy on July 7th, and we do have a surgery, and that surgical code includes the mediastinal lymph node dissection as well. So that gets reflected in the surgery code and the lymph node codes. We have to remember that those fields are intertwined, so they're going to affect each other. No chemotherapy, no hormone therapy, no immuno, no transplant, no other therapy. We do have 4 or more lymph nodes which were removed. We have 20 lymph nodes removed. No surgery to other sites, no palliative treatment. We do code the surgical approach to robotic assisted. We ultimately have negative margins on that surgery, and treatment was given. And all of the rest are our surgical and radiation codes. The date of first course of treatment is going to be the date of that resection, which was 8/8/2023. Surgery was performed, so that gets coded to a 0. There was no radiation, so we code surgery radiation sequence to a 0. Radiation wasn't recommended in this case. The recommendation for the treatment plan was just surgery. No systemic treatment, and all of our radiation codes are going to be 0s because this patient did not have radiation. And then radiation was not recommended. So that is how we code that case. And I believe that is all that we are going to have time for. I'm checking just to see if we have any other questions.
Real quick clarification with the STAS, again, is a spread through airway space, and that is if anyone has a primary tumor that has spread through airway space, that means there's actually a potential for a worse outcome. And so, but a lot of pathologists don't mention STAS, but a lot of the academic places, and looking at the 20 lymph nodes that are being taken out, that means this was done someone who's a thoracic oncologist, not a someone who just goes in there and takes things out. Second thing is, currently the Commission on Cancer, what we are, one of the standards is it's not just the number of lymph nodes, but where the lymph nodes are taken from, mediastinal nodes and hilar node, at least 3 mediastinal nodes and a hilar node. So soon enough, I'm sure that's going to change to where make sure that those criteria are met, because that's one of the quality metrics. Before, we used to say 15 lymph nodes or 12 lymph nodes. But we know that it's not just about the number of lymph nodes, but where the lymph nodes are taken out or lymphadenectomy performed. And then the other question was, patient is a PT2A, so this patient is stage 1B. So the current guideline states that patients should be counseled on getting adjuvant chemotherapy because that can improve survival. The problem with that is the improvement survival is only about 6%. And so it's a discussion that needs to be held. But if it's not offered, I don't think it's correct. It should be discussed. So that's those are the few things that I noticed.
And we always greatly appreciate it when providers document those kinds of thought processes in the medical record. I know I do. so that we know what we've recommended, because sometimes it is difficult from our side of things to be looking at these records and knowing because of this stage, this patient should have had a discussion. So we always appreciate when physicians are good documenters.
Yeah, well, we have to, because like documentation is not about billing. I know a lot of people are doing it because of billing, but it's not. It's for treatment and what you're thinking, so that you could go back and, or someone else to go back and see. And this, the reason why we did that was, the stated above. I mean, that's the most important thing. It's a tool of communication, but now it's been hijacked by billing people.
Well, thank you so much. I believe that is all the time that we have for today. And Ryan has just posted that evaluation in the chat again, and we greatly appreciate you filling it out. Thank you once again to Dana and to Dr. Baik for making this a really comprehensive discussion of lung and esophageal cancer. And thank you all for attending, and we will see you back next week for session 3.
Thank you, everyone.
Thank you, Dr. Baik. It was a great
Okay.
presentation.